so happy to be here. I am presenting before my mentor and my students and somebody whom I taught some months ago. And there is my batchmate, there is my school friend and a new friend. Thank you very much. So, superior oblique and inferior oblique muscles with their range of primary, secondary and tertiary actions are involved in cyclotorsions and vertical ductions. It is virtually impossible to differentiate one action of the oblique from the other. So their dysfunction basically produces a cyclovertical strabismus. Typically, cyclovertical strabismus, we see that comitance is rare. Sensory adaptations like amblyopia, ARC are less frequent. The magnitude of deviation would be small. Nevertheless, it would be very symptomatic because of the low vertical fusional reserve. The normal vertical fusional reserve being 3 to 5 prism diopters. So this is the entire list of various etiologies of cyclovertical deviations. When will you suspect a cyclovertical deviation clinically? Patient would come with complaints of vertical diplopia. An intelligent patient would specifically tell you that the second image is tilted with regard to the first. And the other complaints would be asthenopic symptoms like blurring or headache. There would be an obvious vertical misalignment, which could be cosmetically disfiguring. Some patients will tell you that straight away. And there can be an anomalous head posture with associated neck discomfort. So signs, vertical deviation would be present, extraocular dysmotility, a pattern deviation, and a fundus torsion can be seen. So this is how von Noorden has classified cyclovertical deviations. So as is routine, we go ahead with a history taking and examination with special stress on age of onset, duration of altered head posture, history of trauma, drug intake, comorbidities like diabetes, thyroid dysfunction, history of sinus surgeries, and always probe into a family history of squint, go for a FAT scan, familial album tomography. So this is the protocol that we follow. Note every single point. These are the ancillary clinical tests we go for in case of suspected cyclovertical deviations. So we'll be coming to each of it in detail. So anomalous head posture, this is something which needs special attention, document it straight away. You can quantitate it with an instrument called goniometer, and a photographic documentation also helps. Always differentiate an ocular cause from a non-ocular cause. So what is the easiest way of doing that? You patch one eye, observe the child. If the torticollis improves after patching of one eye, it suggests an ocular etiology. If it does not improve, it suggests a musculoskeletal cause. Look for facial asymmetry. It is important because in cases of congenital facial nerve palsy, congenital superior oblique palsy, there will be a flattening of the face on the affected side. So why does it occur? Because of restriction of normal facial growth by persistent muscle pull on the facial bones to one side. Now, very important it is to observe and document the ocular rotations in detail. Go see the versions first, look for any asymmetry, document the ductions, note the limitations in all 9 gaze positions. A properly performed assessment of ocular rotations will give you an idea about the comitance of the deviation. Grade your inferior oblique, superior oblique limitations. Different grading systems are available for that. And you can actually go for an on-the-spot photographic documentation by using apps like this 9 gaze app. And while you check the motility patterns, do not miss findings like upshoots, downshoots as we get in Brown syndrome and DRS. Coexistent features like globe retraction and narrowing or widening of the palpebral fissure also should be picked up at this juncture. So we go ahead with the first and foremost screening test, that is the Hirschberg's corneal reflex test. So here in this example, we see that the left eye appears to be up. You see the corneal reflex displaced slightly towards the inferior aspect of the pupillary area. So this is a left hyperdeviation. So what is your next plan? You go ahead with the cover, uncover, alternate cover test. You see the very obvious alternating hypertropia. And then you quantify your deviation with prism cover test. Remember, in the case of a suspected cyclovertical deviation, you have to do the tests in right and left head tilts after going for measurement in all 9 gaze positions for near, far, and in case of associated horizontal deviations, neutralize them first and then neutralize your vertical deviations also. Do not miss to document the pattern deviations. This is how you finally make a documentation of 9 gaze measurements. Go ahead with assessment of BSV by making use of Worth 4-dot test that has to be done for both distance and near, and Bagolini striated glasses. Stereopsis tests have to be done for both, again, distance and near. And examination of the fundus is important to pick up any posterior segment pathology that is contributing to the deviation. And it is also imperative to go for a cycloplegic refraction. Assessment and grading of fundus torsion also is very important, especially in a case of suspected cyclovertical deviation. So these are the ancillary tests that you do. Versions you have already done. And while performing your version assessment, you can do PARC 3-step test side by side. So in this example, you see that there is a left hyperdeviation. So what is the first step? You will isolate all the 8 muscles in both the eyes involved in cyclovertical movements. So you have marked all your 8 muscles. So left hyperdeviation means it is due to weakness of the left eye depressors. What are they? Superior oblique and inferior rectus in the left eye. Or it could be because of weakness of the elevators of the right eye. They are right superior rectus and right inferior oblique. So step 1 is done. Go to step 2. You see that the left hyperdeviation is increasing in right gaze and it is not so in the left gaze. So you have to identify the vertically acting muscles in each eye in right gaze. So what are the vertically acting muscles in right gaze in the right eye? They are the superior rectus and inferior rectus, and in the left eye it is the left inferior oblique and left superior oblique. Third is the Bilshkovsky's head tilt test. In that tilt photo, you see that the left hyperdeviation appears to be more in left head tilt, and towards the right, it is not very obvious. So what do you understand? On your tilt, when you tilt your head towards the left, your right eye should extort and your left eye should intort, right? On tilting to the left, your right eye should extort and your left eye should intort. So what are the extorters of the right eye? Extorters are inferior oblique and inferior rectus in the right eye, and intorters of the left eye are left superior rectus and left superior oblique. So you see that the left superior oblique gets marked thrice. So that is the culprit muscle. So this patient has a left superior oblique palsy. So this looks quite easy, but remember the test has its own set of fallacies. These are the entities where PARC 3-step doesn't work well. Measurement of torsion by subjective method, you can make use of a double Maddox rod. The patient has to rotate the rod, still the line images are seen parallel to each other. The problem is that it does not localize the abnormal eye. Now, any patient comes to you with diplopia, you have to chart a diplopia charting. Test is done at 1 meter testing distance. The patient has to identify areas of single vision and double vision, see whether it is crossed or uncrossed, look for tilts, and he has to report the position of maximum separation of images. So these are the examples. Again, Hess chart is there to diagnose and monitor the concomitants of deviation. Remember, you have to first look at the smaller chart, identify the eye with the affected muscle, and the degree of disparity between the plotted point and template in any position of gaze gives an estimate of the angle of deviation. So this is the Hess chart of a right acquired fourth cranial nerve palsy, and this is that of the left eye. Sorry, this is that of a congenital right superior oblique palsy. Now, you remember to do a vertical fusional amplitude test whenever you are suspecting a congenital superior oblique palsy. So this is one test which helps to differentiate a congenital SO palsy from an acquired one. And large fusional amplitudes are typically considered evidence that SO palsy is congenital. Finally, you have to proceed to Guyton's exaggerated FDT to evaluate tightness of the oblique muscles. So this is how you do. Remember to retropulse the globe while you perform exaggerated FDT of obliques. And you have to move the globe supranasally, and then the globe is rocked temporally to evaluate for the tightness of the superior oblique muscle. And then you can grade the tightness as well. So same thing has to be repeated in the opposite direction for testing inferior oblique. So these are the common things which we see in our clinics. So superior oblique palsy, inferior oblique overaction, Brown syndrome, paresis of inferior oblique, etc. So basically I think if we follow this protocol, we can maybe identify clinically itself the involved muscle. Thank you very much. Now I'll be moving to my presentation, restrictive pathologies on obliques. So ocular restriction is the result of either a mechanical tether on eye movements or a leash. Leash is a misdirected force that works against normal agonist function. So with regard to the oblique muscles, we can classify the causes of ocular restriction into these 4 headings. Could be the result of a tight extraocular muscle, as in congenital Brown syndrome, thyroid myopathy, or local anesthetic myotoxicity, or because of structural adhesions, as in acquired Brown syndrome, fat adherence to the muscle or sclera, or congenital fibrotic bands. Then the third group involves orbital mass or a glaucoma explant with a large bleb. Finally, it could be the result of misdirected muscle forces. So these are the headings which we would come to. So Brown syndrome, commonly seen among these list of entities. Consistent findings include deficient elevation in adduction, minimal or no elevation deficit in abduction, minimal or no superior oblique overaction, restricted force ductions, V pattern with divergence in upgaze. Less consistent findings include hypotropia in primary position, anomalous head posture with maintained binocular single vision, and downshoot in adduction. And globe proptosis in attempted upgaze has been thought to be virtually diagnostic of this condition. So this is how you classify Brown. You have congenital and acquired, and in each you have a true congenital Brown and a pseudo congenital Brown, true acquired Brown and pseudo acquired Brown. So true Brown congenital is due to inelastic muscle tendon complex. Pseudo congenital Brown, the result of anomalous inferior orbital adhesions. True acquired Brown, the result of peritrochlear scarring or adhesions, inflammation or edema. Pseudo acquired Brown, the result of floor fracture or inferior temporal adhesions. So we already know the pattern of evaluation for a suspected oblique palsy or oblique restriction. If you suspect an acquired Brown from history or clinical examination, order for additional lab investigations like ESR, RA factor, ANA, and imaging has a definite role. So these are the differential diagnosis of superior oblique palsy, Brown syndrome. You have to differentiate it basically from inferior oblique paresis. Here you would have superior oblique overaction, A pattern, a positive head tilt, and FDT would be negative. In monocular elevation deficit, the deficit will be present in both adduction and abduction. Congenital fibrosis syndrome characterized by limitation of all extraocular movements. And finally, you have to differentiate it from thyroid orbitopathy and orbital floor fracture. In this situation, the elevation deficit will be more in abduction, inferior rectus being the mostly involved muscle. So definite indications are there for managing a Brown syndrome. Indications include primary position hypotropia, or when there is a loss of anomalous head posture, which suggests loss of binocularity, and there is a risk for amblyopia in that situation. Observation is advised, but do not expect a spontaneous regression in congenital Brown. Acquired Brown, systemic evaluation is mandatory. You treat the systemic condition, and local injection of corticosteroid in the region of trochlea is an accepted method of treatment. Surgical treatment, Madam would be elaborating on that. These are the different surgical procedures carried out. Now, there is this thing called iatrogenic Brown syndrome, the result of superior oblique tightening procedures. So, you can actually prevent it by avoiding over tightening of the superior oblique tendon. This is also seen in glaucoma valve surgeries or following scleral buckling or following sinus surgeries which damage the tendon trochlea complex. Then comes the anti-elevation syndrome, which is characterized by limitation of elevation in the abducting eye due to restriction produced by the transposed inferior oblique muscle. And there would be a pseudo-inferior oblique overaction in the adducting eye following Herring's law of equal innervation. So this is the image. Now, why does this occur? With placement of inferior oblique muscle more than 1 millimeter anterior to the insertion of the inferior rectus muscle in IO80, or when the new inferior oblique insertion is splayed or spread too widely following IO80, this particular syndrome happens. That is because the posterior fibers of the inferior oblique carry the neurovascular bundle, and when the posterior fibers are anteriorized, this neurovascular bundle tethers the eye, thus limiting elevation. So treatment is revising the transposed inferior oblique insertion, moving it more posteriorly, and then causing it to bunch at the new point of insertion. It should not be splayed. And when you have already created an anti-elevation syndrome by performing IOAT in one eye, maybe you can go for a balanced anti-elevation in the other eye by repeating the same in the other eye. That is also advocated. Now, I came across this thing suggested by Dr. David Hunter. It is inferior oblique myotoxicity from local anesthetic injection, characterized by delayed onset hypertropia with definite fundus extortion in an eye that has undergone a surgery, and it is consistent with inferior oblique overaction secondary to presumed contracture of the inferior oblique. So the proposed mechanism is like peribulbar block causing localized muscle damage to inferior oblique. Both lignocaine and bupivacaine have been thought to produce the damage. Here the muscle fibers get replaced by fibroblasts. Fibroblast proliferation further results in contracture of the inferior oblique, which manifests late as hypertropia, fundus extortion, and diplopia. Resolution on weakening of the contractured inferior oblique was also supportive of this entity. Another entity described by Dr. Kushner is superior oblique tendon incarceration syndrome. It also produces a restrictive oblique cyclovertical deviation characterized by restrictive hypertropia and encyclotropia following prior surgeries on superior rectus, superior oblique, or scleral buckling.